genetics in retinoblastoma. I know after a good meal, genetics is not a very palatable topic, but I'll try to make it interesting with few of the case scenarios so that you understand the relevance of the genetics. Yeah. So, first, for all of us to understand, we need to understand that the 4 bases that are very important. That is the adenine, thymine, the cytosine, and the guanine. So these are the 4 important bases, and any skewing in this is what results in the formation of a retinoblastoma or a tumor. So I don't know, just to keep your interest high, any guesses on how many bases are there in the human body? The human genome has about 3 million base pairs. 3 million base pairs. And any skewing in any of these will result in a problem. So we have to remember a few terminologies, and I'll explain what the few terminologies are. So you must understand these letters should not be mismatched. So A pairs with T, C pairs with G. So this is very, very important. Now, in nonsense mutations, the nonsense mutations is one of the important ones we'll be seeing in during the course of my presentation. They are caused by a single base change. A single base change creating a stop or truncating. Anything that stopped or truncates the entire protein. So you must remember that about 30% of the retinoblastoma mutations are nonsense. They can be the definite cause for the disease. So just one single change can result in stopping or truncating a protein, which could result in 30% of the retinoblastoma hereditary cases. Now this missense mutations causes change of an amino acid that can alter the protein sequence, and it's more or less relative to the when you compare it with the nonsense, the missense is slightly less penetrant. So there is a role for penetrance. The nonsense has a higher penetrance, whereas the missense has a lower penetrance. These are also important for us to understand the genetic inheritance pattern. The silent mutations do not cause any problem. So that's why when you screen the gene, you'll have a lot of mutations, but all of them are not very relevant. Now, why are we talking so much about this RB gene? That's the gatekeeper. When something goes wrong with it, ends up in proliferation of cells, resulting in the tumor formation. That's all you need to remember. Now, in retinoblastoma, you know the non-heritable adds up to about 60%, while the heritable adds up to a 40%. And it's very, though the ratio is a little lesser, it's important for us to look at the heritable entity, because this 40% is going to cause a problem in the offsprings, and there's going to be a whole community of patients with retinoblastoma. So that's very, very important for us to concentrate on the heritable one, and hence the heredity aspect is added to the classification. So you all as students should remember that one allele in the RB1, as far as the inherited retinoblastoma is concerned, one allele is already inherited. That is, every cell in the body will have that mutation, and the second mutation happens in the retina. So this is important for us to understand. So that becomes the inherited entity. Whereas in the sporadic entity, which is non-inherited, you will have both the mutations occurring in the retina, which means the rest of the cells are devoid of the mutation. So what we did initially to start with was we revisited the nonsense hypothesis. I think somebody didn't like the nonsense hypothesis being revisited.
Lots of technical
May I
issues in
have
this
some?
hall actually.
This is a jinxed hall.
All right.
Yeah, we need someone who is like.
I
really
thought
good
only
in
the
this
ophthalmic
sort of-
arena didn't like us. Even the audiovisual don't like the oculoplasty. So as I'm waiting, I'll just continue talking about we used to have patients, either of the parent would come and give us a very vague history of having lost an eye, and it was very difficult for us in those days. Not that we're all antique, but at least 20, 30 years ago, not much of importance was given to a socket which did not have even an artificial eye. I think probably about 20 to 25 years ago, it was not uncommon for us to see empty sockets, and we had no history from the patient telling us what exactly went wrong. So on looking at it very carefully, if you look at the Knudsen's hypothesis, which clearly gives you the two-hit theory very well, explains it very well. The one thing that was very glaring was we used to have bilateral cases presenting to us very early and unilateral cases presenting to us later, and which corresponded to the two-hit hypothesis as well. That was the first thing we did. Then we strategized and we started doing an analysis where we established a stepwise methodology for analysis. First, we did the Sanger sequencing. All of these are terms you might have to remember for your examination purposes, and those interested in research have to read a little more about this. So the basis is what I explained. It is all to do with those pairs, and if those pairs are skewed, you will end up with having a nonsense or a missense mutation. A nonsense mutation has got a high level of penetrance, and nonsense mutations are predominant in our population. So here we looked at the point mutations as well, and then I'll talk about this MLPA a little later, where you'll have deletions and duplications. Now this facility is what helped us to run our testing very fast. The next generation sequencing facility helped us to find out the variants in the RB1 which could not be identified with our conventional methods. So this was important for us. And the other important aspect is it's faster and gives you in one go you can put about 100 samples altogether can be screened. So the next entity is the promoter methylation analysis, which was found out in about 4 of our patients out of the 500 and odd specimens that we handle, the patients that we handle. But these were not found in the blood. So it is important to note that this promoter methylation actually was found in the tumor and not in the blood. So this is an epigenetic change that has occurred and is somatic and cannot be inherited by the next generation. It's very important for us to understand this. So when something is not found in the blood, it will not be inherited by the offspring. The next one is the MICN amplification. This is a proto-oncogene and its amplification is independent of the RB1 inactivation. This can cause RB. This per se can cause RB. So the MICN amplification per se without any mutation can cause RB. So high MICN copy numbers was seen in about 5 of our tumors of unilateral patients. Please remember, these are unilateral patients. Often we are told that unilateral patients do not pass on the tumor to the offspring, or it need not be inherited. It's not true. I'll show you examples. MICN has another aspect to it. It's an aggressive tumor with a very poor prognosis. Again, all of these will have relevance in terms of management, and all of these will help us to prognosticate and tell the patient well ahead whether this is going to be chemo-resistant or chemo-sensitive tumor. So in our map, we had about 140 mutations which were noticed, of which 20 to 24 of them were very unique to our particular population. That is, the 500 and odd cases that we screened, and of which nonsense predominated, followed by missense. And I told you earlier, nonsense has a high penetrance. Now, so we established the genetic testing center, and we have a sensitivity about 95% for somatic mutations and 85% for germline mutations. And this is actually, I would say, we are not very behind the other established centers in the world. And what's more important and relevant to us is the cost has been brought down significantly from $1,800 to about $150 to $200. And the time taken for the entire testing to be completed is about a month, which means the patient comes first a month and gets the examination done. In some cases, enucleation can also be done. Sometimes we start off with chemotherapy. So when we start the first cycle of chemotherapy, before we start, we draw the blood and do all the workup. And then once the patient comes back for the next chemotherapy, we're able to provide with the results. So what do we do actually in terms of the testing, and what is the relevance for a patient? You are able to prognosticate one, but more importantly, you're able to predict for the offspring, for the sibling, and also you can preempt whether this patient is going to be a bilateral case in cases of unilateral cases. And I'll show you some of the examples. Now, this was a child who was brought with a bilateral retinoblastoma. Unfortunately, we had to enucleate one eye. But on history, we found out that the mother had a empty socket. If you notice, the right eye is an empty socket, and she has had an enucleation, but she did not give us any history as to what had happened and why the enucleation was performed in this patient. And eventually, we drew the blood for both the patient and the first child, and found out that both the mother and the child had a similar mutation. The pattern was very similar, and as we were doing it, the next child was ready to be born, and we predicted that the next child is going to have a tumor, and the child did have a tumor, both eyes. And since the child was brought in as early as 12 days, we were able to treat both the eyes and not only salvage the globe but also the vision. So that is one way of predicting the occurrence of retinoblastoma. Now here is another classic example where a twin was brought to us. One twin had an obvious retinoblastoma while the other had a suspicious lesion. So in order to find out whether the other twin is also having a retinoblastoma, we had to do an analysis, genetic analysis, and we found out that the other sibling did not have any risk of retinoblastoma. So we need not unnecessarily keep giving anesthesia for the patient and examining the other twin which had a suspicious lesion. Another example here is, this was a unilateral retinoblastoma group E with no family history, and a germline mutation was identified in the blood. So now I would emphasize that it is very important for us to do genetic analysis even in unilateral patients. Now this is another example where the father was an unaffected carrier. There was a germline mutation identified and the patient was closely monitored. So the right eye had group E retinoblastoma, and as the patient was getting treated, the risk was predicted that the next sibling would have a chance of retinoblastoma, and the sibling screening was done, and the familial germline mutation was found. A high risk of developing RB in the sibling was predicted. Father's eye was normal. So please remember, father is an unaffected carrier. The father's eye was normal, and the first child had a similar mutation like the father. Father unaffected, child affected. Sibling had a high risk of, the next sibling had a high risk of retinoblastoma. So the next sibling was brought in very early and found out that both the father, the children carried the same mutation. So why am I stressing on early arrival is when the child is brought in early, the treatment is easy and you can salvage not only the globe but also the vision. Now there is another aspect to it. Now with all this happening, people have started coming forward. The old cases of retinoblastoma now are coming to us asking for a genetic analysis. One such patient had turned up and said, I would like to get screened to know whether when I get married, would my offspring be affected? And genetic screening was done, and fortunately the blood showed a negative for mutations, and then she also has given birth to 2 children, both of whom have been screened, and they've been found to be negative. Now, secondary cancers is another aspect. Now again children are coming forward and asking for any possibility of secondary cancers, and with the genetic screening done in the blood, it has been proven that some of the children are negative for mutations, and hence there's no risk for secondary cancers. Now this patient, the grandfather had a brain cancer. There was a history of some cancer in the family, and there were generations which are affected. So here the history goes such. The proband had a bilateral RB, and this particular deletion, you don't have to go into that aspect. This particular deletion was inherited from his father, who again is an unaffected carrier. Now we explain the risk of RB in the next sibling. Immediately after the birth, the child was brought in, and fortunately in this case, the next sibling was found to be normal. So there are very good aspects to it. One, you can give a negative result, which is very good for the patient. You can give a positive result, which again is good for the patient because they are brought in early and treated, and the vision and life is salvaged for such patients. And of course, we had one unfortunate incidence where the proband had inherited the retinoblastoma. The proband's wife was pregnant, and we had to do an amniocentesis, and we found out that the fetus also had positivity. Unfortunately, the twins, they had to terminate the pregnancy, but we have to be very, very careful in terms of counseling these patients. The onus is on the patient to determine how to go about. So here it's only the results we have to provide for the patient. So in summary, tumors are caused by genetic aberrations. It does not mean that all patients will inherit the disease, and it does not mean that tumor in all cases are heritable by the next generation. So we'll have to understand this very clearly. So in terms of heritable disease, there is high risk of other cancers, increased risk of RB in siblings and offsprings, and usually the alterations are found in the blood. Whereas in non-heritable, there is no risk of other cancers. There is reduced risk of RB in siblings and offsprings, and usually the alterations are identified only in the tumor. Thank you very much.
Thank you, ma'am. That was very useful. For all of us who are seeing retinoblastoma patients, the one question that we are frequently getting is that, what will happen to the subsequent children, and what will happen to the siblings of this particular child. And there's no precise way to predict that, and unless you do that genetic analysis, which is very important nowadays, and with the facility being available at such low costs that you have mentioned, that really becomes very I would say feasible for anybody who's interested in knowing the exact prognosis and the familial the implications of having a retinoblastoma gene in the family. So thank you very much, ma'am. And also, if these patients are brought in early, when you can really pick up the gene in the family, that can really save their vision, not just the eye. So that's the importance of this subject. It may be a little tough to understand, but it's really clinically very relevant, and more clinicians and geneticists are working together everywhere else in the world, and I think that's something which will happen in future in India also. So that's where probably